So what we're going to talk about today are signs and symptoms of cognitive impairment, and then how to initially assess for it in a primary care setting. If you could go to the next slide, please. We got to say this these days. I really don't have any conflicts for doing this. But I get funding from different people to do different things. But this is pretty straightforward, and I'm not hawking any particular kind of system or anything like that. I always say when I'm talking about disclosures, the only conflict I really have is just remaining regret about my mother, but that's okay. We'll leave that pass. Next slide, please. So, signs, symptoms, and assessment for dementia, major neurocognitive disorder, these neurodegenerative conditions. So what we'll talk about today is why it's important to recognize it early. You know, some people think they don't want to know. I was actually in a meeting earlier and somebody said, you know, we can predict if you're going to get this. And the other person said, I don't want to know. Actually, I disagree with that. I think it's really important to understand this and know this. It can be scary, but understanding it early has some value. We'll talk about what some of the early signs and symptoms are. We'll talk about how to objectively assess this. And by this, I mean how to use a tool or a measure. And then what you need to do as a clinician to kind of get a sense of this, because we are more than just assessment devices. There is still a clinical art to practicing healthcare and medicine, and we want to talk about how to do that also. And then, I don't know what that typo is there, who to refer, but actually what it meant, what it was supposed to say is when to refer. And then have a brief clinical example that we can kind of walk our way through and kind of think about some of these issues with and what you might do and what you're comfortable with. Next slide. So why is it important to recognize these cognitive disorders early? Probably the most important thing is that future treatments are really going to be geared towards targeting people very, very early in the disease course. In fact, the Biogen drug, which is under consideration with the FDA now, is going to be limited to people who don't actually have a diagnosis of dementia or are very early in the course. And we think that some of these treatments will work best if we don't really have to kind of deal with a lot of damage that's been done already. So going forward, identifying people early and getting good at identifying people early will be really important, because the treatments are really going to be geared towards early in the course, maybe even before somebody's really having too much in the way of symptoms. So that's one reason that it's important. The other reason is if it happens to be something other than Alzheimer's or another neurodegenerative disease that is actually correctable, you want to catch it early before damage is done, or so that the patient just isn't suffering. If it happens to be an unusual case of normal pressure hydrocephalus, and you can catch it early, you can correct that potentially and prevent further decline. There are a couple other cases where, and a couple other causes, that you can correct these kind of cognitive or memory problems. So identifying it early for those rare cases where we can reverse it is important. One of the other issues is if you're interested in participating in clinical trials or other research, getting in on it early is important from a research and scientific standpoint. You know, there have been 500 clinical trials done for Alzheimer's disease with very, very little and limited success. We have to get people to participate in this, and it's much better if we catch them early in the disease, because that's what we want to be able to target. So if you have patients who want to give forward for their families because they want to figure out what's going on, catching them early again is good for the research. Some of the other issues are a little more practical for identifying cognitive disorders early. These are safety issues, because with cognitive disorders, there are risks to safety for the patient and their family. For example, cooking, not being able to remember that if you left the stove on, you can create a problem that way. That's a safety issue. Driving is another big one. You want to catch these things early and be able to talk proactively about it so that you prevent problems and you prevent risk for people. And then finally, quality of life. And Dr. Miller, when he gave his presentation last month, he talked some about this, and this is really an important issue to me. Talking about and thinking about identifying a problem, even if we don't have a treatment for it, you know what it is, you can plan and make decisions, you can be part of the thought process for what's going to happen, how you're going to spend your time, what you want to spend your time doing. So even if we don't have a treatment yet for it, knowing what it is, having some sense of the time course, you can make life decisions that are going to make things easier for you, but also just improve the quality of life because you'll spend time doing things that you want to do with your family rather than things that are less meaningful. Next slide, please. So what are the early signs and symptoms of a neurodegenerative disease? Anything, all right? The reason this is because the brain controls everything about us. And so when you have a neurodegenerative condition, somewhere in the brain, it's going wrong. And wherever in the brain that is, you'll have symptoms that come from that area of the brain. The most common one is short-term memory. That's what most people are aware of. It's a complex process, but that's the most common complaint people come in with. But literally, it could be anything. Any change in behavior or cognition could be a sign of an early neurodegenerative condition. Not to be overwhelming, you need to kind of keep that in context. And now let's deal with the most common ones, which is short-term memory. When we talk about short-term memory, we talk about remembering things from today or the day before, not long-term memory from when you're growing up. That's the most common symptom that people talk about. There is some natural change with that over time as you get older, but it shouldn't be impacting or interfering with a person's life. Other signs that we see of other neurodegenerative conditions, including Alzheimer's, are word finding problems. What do you call that whatchamacallit thing over there? Hand me that, well, you know, what is that thing? Looking for those kind of changes in accessing, pulling out words that are very common. Another common change is change with space. Finding your way in space, understanding space, knowing about and judging distances. Unfortunately, one of the best predictors of this early on is problems with driving. And so that may be difficulty backing up because you can't judge or figure out how to turn the wheel to make it go a certain way, or problems judging space and clipping curves, problems pulling into the parking space and things like that. That's another common thing. Now, your brain takes care of things more than just cognition. So sometimes we'll see new onset symptoms that are more related to behavior. Changes in affect, like depression or anxiety, or changes in personality. Now, a lot of people think that when you have a neurodegenerative condition, your personality changes. And so sometimes you can have new symptoms that you didn't have before. So maybe you were quiet and now you're boisterous. But it can also be magnification of existing problems. It can go either way. The most common thing that we see that we worry most about is when people, as the kids call it these days, lose their filter and are more likely to say things that they wouldn't have said before. But it could be magnification of prior symptoms. And finally, one of the other things that we look for is new onset psychotic symptoms. So this isn't somebody who's 50 years or older. They have an onset of hallucinations, auditory or visual, or they start developing paranoia, delusion. When that happens, if there's not a clear indication that this is medication related, I always think that this is the onset of a neurodegenerative condition as they get older. And that can be that first symptom that you see. And again, remember, it depends on where in the brain this degeneration is happening. And if it's happening with some of these complex behaviors, that can be the first symptom that you see. Hallucinations and delusions are pretty common. They're really common in patients who have Lewy body dementia, but they're also common with the other dementias also. There's not a dementia out there that doesn't have those kind of psychotic symptoms at some point. And then finally, many people don't think about this, but changes with motor skills and coordination can be also an indicator of a degenerative condition. We think about Parkinson's disease. That is a neurodegenerative condition. It has changes with cognition and affect associated with it, but there are other variations of different dementias that have changes in motor skills and coordination. that are indicators also. So unfortunately, what you're left with is that patient comes into your office. How you doing? Any new changes at all? Potentially anything that they describe could be an indicator of this. And so the next step is really to kind of think about, is there kind of an automatic explanation for this, or is this one of those signs or symptoms? These are the most common ones that I flag, particularly if they're new symptoms and the person hasn't had them before, and then the time and course are gradual. If you could go to the next slide, please. So, if you read what is put out by consensus statements, and no offense to our friends from the Alzheimer's Association, thank you for your support. I love your organization. But there's consensus statements that come from the Alzheimer's Association that say you've really got to objectively assess things. And I think that that's important. And particularly when you're starting out in this, if you don't know much about it, having some way to objectively do this can be important, and it can get you started on this. But I don't want to undersell anybody's general clinical skill. And so one of the indicators is maybe on your Medicare wellness visit, you can ask a couple questions and you can check for this. Well, maybe you'll get a flag with that and maybe you won't. All right. Maybe if you see that, you can do one of these very brief 2 to 4 question screens, which is much quicker than doing a full MMSE or a MOCA. And it might flag some people, but you end up with the same limitations that you have when you do a screening test like the MMSE versus sending somebody for a full neuropsychological evaluation. It's a screener. You might catch things, but you got to know that you're going to miss things also. And so that's where your clinical skill comes in. And that's where your knowledge of these patients comes in and whether you've seen this before. Because I know you don't have a lot of time in a wellness visit to really go in any depth, particularly not the kind of depth that Dr. Wilhelmson or Dr. Keith or I do when we're doing one of these special evaluations. So you got to kind of learn to catch some of these flags that you may see so that you kind of get that sense. And then if you're not sure, you can start with a pretty quick screen. And there's a couple here that I'll describe that I've looked at that are okay. Personally, we use the MMSE here just because I've used it forever. You have to pay for it now. It used to be free, but you have to pay for it.
That's why I use the MOCA.
But the MOCA, you're going to get trained for now, or they won't give it to you. And pretty soon, all of these things are going to have something associated with it. So we go ahead and pay for the MMSE here because I like it and I've used it. And it's good if we're going to publish some stuff. But there's other options. Can we go on to the next slide, please? So what are some of these brief screens that are out there? So there's the memory impairment score. All right. Now this is a pretty good screener if you're worried about memory. But remember, memory change was only one of the things on the list that could be an indicator of a change or the beginning of a neurodegenerative disease. So if it's not related to memory, if they're having some other kind of problem, this is a terrible test to do. But essentially what you do is you give people 4 words. Each word comes from a different category. You associate the category with it. And then a couple minutes later, you have them recall the words. If they can't recall them, you give them a cue and see if it helps. And I think if you score less, then you get 2 points if you get it spontaneously, 1 point if you need a cue. If you score 4 or less, that's bad. So it's a pretty quick and easy screen if you're worried about memory. All right. There's all of these tests, by the way, you can Google them and you can get the forms if you're interested. There's another test called the Mini-Column, which just uses 3 words to remember. And in between, you have them do the clock drawing test where you say, all right, here's a circle, put the hands in and all the numbers and set it to 10 after, what is it, 10 after 11, Dr. Keith? Yeah, set it for 10 after 11. And you make sure they can do that normally. And then there's the general practitioner assessment of cognition, which is a little bit more, all right? Gives you a little bit more memory, a little bit of other things, and it asks you to speak with an informant also. And I'll give you an example of that if we can go to the next slide. So this is actually pulled this up from a different presentation. And so the first thing they ask is, or they do, is they're going to give you a name and an address, and it has 5 parts to it. So you're going to do more than 3 words. You're going to have 5 parts to an address. You can rehearse it to them. You can change that address if you want to make it something local. But don't make it that exact town, or it's going to be too easy. And then they ask the date. And I want to make an important kind of note about this. Orientation to time is a good indicator that somebody's having memory problems because they can't keep up with that. So if they're off by the date on one, you know what? I'll give them a little wiggle room. But if they're missing the month or they're missing the year, that's a big red flag for you. So even if you don't do this test, getting some sense of orientation to time pretty quickly can be helpful. All right? And then you ask them this broad question. You do the clock drawing again on this one. You ask them a broad, which looks at visual, spatial, and planning skills. Then you ask them for some recent information from the news. So you say, so tell me something that happened recently in the news. And they're going to say, oh, there's that infection. All right. And you're going to say, okay, so tell me something more about it. And so the patient that I saw yesterday was talking to me about that second infection. And I was like, that second infection? She knows somebody who got that second infection. And she's got such terrible word finding problems, she was trying to say COVID. So you ask them for something specific, you see if they can give you a detailed answer from something recent, and then you check their recall. So really, you know, I mean, this is the mini cog plus an extra word or two, and you check for orientation to time. Okay. The nice thing about this is they then do the next step. Next slide, please. So if you think they're having some problems, then you go and you ask an informant what they think. Does the family member notice any of these kind of changes with the patient? Is somebody else noticing this? Because remember, if you're having trouble remembering, you may not remember that you don't remember. You may also have impaired awareness independent of your memory. And so getting collateral information can be helpful. You can do this without a form, by the way. You can just ask a family member, do you notice memory problems? But you have to gauge whether they're willing to talk about that with the patient or they're minimizing because they're worried and afraid what's going to happen. But getting this informant information can be useful. Next slide. Okay, so those are a couple standard tests in addition to the MMSE, the MoCA, and the other one that's commonly used is the SLUMS, the St. Louis University Mental Status Test is what that is. All right, so remember, any tool that you use is only as good as the clinician using it. So you have a patient, all right, you get their labs done, you look at their labs, there's a range on the labs. You as the clinician has to make a determination as to whether that range and if the person is just outside that range is meaningful and what you're going to do about it. So there's still a clinical art to using the outcome of that assessment. And these cognitive screens are the same. Clinically, what I always do is look at the patient, listen to the patient. Self-report is important. It used to be years ago that we thought that anytime a patient was complaining about their memory themselves, that was a sign that they were just depressed and worried well. We didn't think that they had any insight into this when we first started out this business. But now we know that some patients are very self-aware and pick up these subtle problems. And that if you study these patients who have very, very early reports of mild changes with their memory, even though we can't measure it, they actually, some of them go on to develop dementia and Alzheimer's disease. So that patient self-report can be helpful. Now, sometimes it's not because they have no awareness. But if they're complaining of it, take it serious, look at it. Family report is also important because, again, that patient may not remember, whether you do it from a structured report form or you just ask the patient, do they see any problems? Are they worried? What is their concern? Now, I'll say this with a caution, watch out for conflict because families are full of conflict. And there could be problems and things that you don't know about going on behind the scenes that may make a family want to report problems or to minimize problems. The final thing that you want to do clinically, and you can do this with a form or you can just ask, are these problems with thinking, with memory, with language, with behavior, are they impacting this person's life and function? Because that leads to a different diagnosis. If it's more of an irritant, it's still mild cognitive impairment. But once it creates functional problems, then it's a difficulty. Finally, the other thing that you want to clinically assess, and you can do it pretty quickly, is how's the caregiver doing? Because if it is obvious to you that this patient does have Alzheimer's disease or frontotemporal dementia, it's a bad diagnosis, we don't have a cure for it, it's going to take a while for this thing to progress, and the best outcomes happen when the caregivers are doing well themselves. So next slide. So one of the things that we do in our clinic here is we actually spend a fair amount of time assessing how the caregivers are doing. And we have a new kind of battery of tests that we put together that we're starting to use. But I went back to some work that one of my colleagues did with us here many, many years ago when we first started working with these populations. And we came up with a few basic questions that you could kind of whittle down that may tell you and give you information about, hey, pay attention to this caregiver. The first questions come from what's called the Zarit Burden Inventory. And so it has many, many questions in it, but these were the essential questions. And so if you wanted to, you could take a question or two from here and try it out with some of your patients or their family members and get a sense of whether you think these have some usefulness for you to quickly ask or to check. These questions actually pared down did better at predicting the overall outcome and well-being of the caregivers than did a standard depression inventory, by the way. And then you can ask a question or two about how much being a caregiver has a negative impact on their ability to do other things in their life. And pretty much anything that's flagged down there at the bottom, you need to pay attention to. Anytime they say, even a little bit, this is impacting my sleep, my ability to do other things around the house, even if it's just a little bit, you need to pay attention to that. So don't forget to also assess the caregiver. Even if you do it very quickly and get that sense of it, then you can move it along. Next slide, please. Okay, so what about with the patient? So without doing a formal objective screen, there are things that you can get a sense of just from your interaction with the patient, particularly if you've known them for a few years. What are the behavioral indicators of memory change? So did the patient not show up for their appointment and they're almost always there for their appointments? Is there a problem with their prescriptions? Did you have to call it in a couple times because difficulties were happening with picking up the prescription or taking it incorrectly? Those things you can get a sense of from your staff, maybe behind the scenes, that would give you some hint. And then the thing I always look for within a session, and then when talking with family, is a history of repeating information without recognizing that they're repeating. That tells you that their memory system is not consolidating and putting away new information. So just before I came in here, we were doing a new assessment for a patient in our clinic. And I noticed that she told us the same story twice within our 30 minutes that we were together. And to me, that was that red flag that popped up and said, ah, here's a problem. Now, it may be between visits or it may be within a visit, but that's always a big flag for you. But other things that tell you, maybe a change in appearance, a change with how they speak or communicate. Maybe their speech sounds differently, and that may be an indicator of some kind of motor problems. Or maybe it takes them longer to explain what's going on, or their speech is empty. Maybe they say they have no problems when it's clear that they do have problems. No, there's no problems with my diabetes, and their A1C is way out of whack. Any changes with affect and how they look and how they interact, and then of course, acting out of character or behavior. And that may be something that your staff tells you about in the waiting room when they're sitting there with other patients. I'm assuming that this is not in the middle of a pandemic, by the way, when you actually have a full waiting room again in the near future when we all take the vaccine. So next slide, please. Okay. So who do you refer?
So you have this information, you get these screens. When do you actually do something with this? Or what is it that you do with this? You know, it comes down, if you're a primary care practitioner, it comes down to what your comfort level is with these diagnoses and what you should do. If you're comfortable with it, you may not need to refer. You may recognize this and see this. Patient comes into my office, they're repeating information. The family is talking about them repeating information. This has been going on since you saw them last. You notice that they have trouble getting their words out now. They seem a little more anxious, but not terribly anxious. All right. They don't have hypertension, diabetes, or anything else that would explain this. And so maybe you feel like they might have the beginnings of Alzheimer's disease. You give them a screen, they're positive on the screen. You give them a MOCA, and it's clear that they have Alzheimer's disease. You do imaging to rule it out. You start them on Aricept, maybe you're fine with that. But if you're not comfortable with this, if you don't have that clinical feel for it, or you're not sure what the next steps are, that's a good time to refer. If it's unclear from the screening what's going on, or it's an unusual presentation, or you're uncertain, it's okay to refer. Those are the cases that we love. Those are the cases that we do really, really well. We'll take care of easy, but we also take care of hard or uncertain. So it really comes down to what your comfort level is. And our goal of doing this echo is to increase people's comfort level with these diagnoses. If you see them after a while, you hear about it, you get comfortable with it, and you know you got backup, it's easier to take care of people closer to home. That's what echo is really all about. But anytime you have uncertainty, come to us. You can send us a message, or you can send us the patient. We'll be glad to look at them. If you want them back, we'll be glad to send them back, and be glad to consult and talk about and teach about how to treat and how to manage these symptoms as they go on. Next slide, please. All right, back up for just a sec, sorry. So before we go on to this case example, let me just kind of summarize here for a second. So unfortunately, your brain controls everything. Anything can be an indicator of a neurodegenerative condition. If you're gonna bet, put your bet on memory. That's the most common symptom that's out there. Pay attention to memory and whether it's changing. If you're gonna bet after that, you're gonna bet if they have memory problems, it's most likely Alzheimer's disease. And most of the time, you'll be right and you'll be okay. But if it's unusual and you're not certain, we're happy to see them and we're happy to help you with that. Get comfortable if you want to use a screening tool with doing that. Learn about it, know its limitations, because they all have them. If this is an FTD and you give them a memory test, the screen is not going to help you with that. So learn and understand those differences, but always feel comfortable reaching out and having us help if you're interested or you're uncertain. And then use your clinical skill and judgment. The other thing to keep in mind with these things is if you're uncertain, it will always reveal itself. And so I remind myself of that sometimes we try to make these great diagnoses just in one shot, and we can't do it because nobody's that good. But if this is a neurodegenerative condition, it will show itself and it will reveal itself over time, and that's okay. Usually pretty quickly, you can tell if you have an emergency and you need to deal with it. Otherwise, you actually have a little bit of time to help figure this out, and it will show itself. Okay. Brief case. What I'd like to do with this, if it's okay, is have people kind of chime in about what they think and what the next steps are. So we'll have a little bit of information. We'll have a pause. I'd like to hear people speak up. Maybe not just the people from the memory team itself here. Would be good. So some of our people who have signed on, but if it comes down to it, I guess the memory team here can chime in. So this is a 68-year-old woman.
who has a history of lifelong mild generalized anxiety, or what we call worry-wart. More recently, she's developed diabetes. She has hypertension. She has some coronary artery disease with a couple stents that were placed a couple years back. She comes in complaining of problems with her short-term memory, and she's worried that she's going to develop or is developing Alzheimer's disease. And what she says very clearly to begin with is she does not want put her family through what she saw her mother and her grandmother go through when they both had that disease. Next slide. So, person comes in, these are the complaints, this is what they say. So I'd like to hear from people about what they might do in this situation. And then on the next slide, which we're not going to show yet, all right, we'll have what I kind of came up with. So anybody have any thoughts about what they want to do?
I do. I would, so I would find out more detail on what she means about her concerns about her memory. What is she experiencing, and ask her if her family's noticed. And then I would do a little, probably the mini cog is what I usually do, although I really liked hearing about this general practitioner assessment of cognition. I think I might start using that. So those are the two things I would do, is get more detail from her about what does she mean, what are her concerns, what does she notice, and then do some kind of mini cog.
Excellent. Okay. Anybody else? I know Rashi would rush right to an MRI scan, and Rudy would say, let's do a biopsy so I can look at the tissue, but we're not going to go that far at this point. So, check her labs.
Yep. Mm-hmm.
Excellent. Good question. Good point. Thank you very much. So if we could go on to the next slide, let's see what my thoughts were. Oh my gosh. So let's get an example of what her memory problems are like, including the time and course of these changes. Let's go ahead and screen her memory. Let's check her labs, and let's check in with the family. So guess what? 100%. You guys are awesome. Excellent. Good. All right. So next slide. Let's see what we learn when we do this. Okay, so when you ask the patient what's going on, she says she walks into her room and forgets what she's going to get. So that is the most common complaint that patients will talk about. And can be a flag for memory, but it can also just be attention span.
So common in the world now.
Everybody does that. Now, she also says that her family tells her that she tells them stories that she's already told them. Boom. So that's a little bit of a flag. So in this case, I just did this new memory impairment screen, and they're right in the middle between whether they really have a problem or not. So it's right in that range. We check the labs, and vitamins and A1C are all good, and the thyroid is fine also, so there's nothing there flagged with the labs to give us any kind of idea or suggestion here.
I have a thing that I would ask that you didn't ask.
What's that?
I want to know a lot about their sleep history.
Their sleep history. That's an excellent point. Good, good. So,
I have a screen for sleep apnea that I use all the time.
So, and it is a correctable problem. And so when patients are not sleeping well, it will affect how well they consolidate new memories. If they have sleep apnea, they're snoring and these other indicators, and you get that corrected, it can improve their memory. So that's an excellent point. Thank you. Next slide, please. So we talked to the family, and the family says there's a 1-year history of gradually declining short-term memory. Recently, they noticed that she paid a bill twice and didn't recognize it. She repeats herself and isn't aware about it. She's more anxious, worried, and tearful, and says all the time when she doesn't remember things, I don't want to burden you, to her family. Next slide. All right, so we got a little more information. What are we thinking? What are the next steps after this?
You can make a diagnosis of MCI right now.
You could. What do you think?
Yeah. Well, you can make a diagnosis. I don't know, at this point, it would be mild cognitive impairment, but definitely, I think it's the point to talk to her and the family about what they're noticing, and that, you know, clinically, I think you can validate it. I would like to ask about, at this point, getting an MRI, just because of her history of diabetes and heart disease. I mean, I don't think that you need that to make the diagnosis of cognitive impairment, but to maybe elucidate what the cause is. Would that be helpful?
Yes, that's an excellent point. Clearly, what I hear you saying is that you have clear evidence there's a problem. We need to figure out what the next things are to do, because there are clearly some next steps that you might take. Okay? Any other thoughts?
I particularly want to fill out more of the history about whether the person is more hypervigilant about things that they've been doing all their life versus, you know, in the worried well, it's common for people that project and think that their cognitive changes that they have been having all their lives. I mean, the cognitive problems, like, I'm terrible at remembering names. I just am. I've been that way since I've been a teenager. But if I was hypervigilant about it, I would start saying, oh no, this is the beginning of cognitive impairment as I
Right.
get older. And I think that walking into rooms is an example of something that is like that most people have done it their entire life. And so trying to sort out whether it's likely to be attentional in the sense that they're distractible
Right,
is something that's helpful.
right.
Especially see that attribution in people who have a parent who did have dementia.
Oh, yeah. They freak out.
Yeah, a similar thing to that I actually kind of have a question about is anxiety and depression. So would it be appropriate to do anxiety and depression screens here in sort of a chicken and an egg thing? Is she anxious and tearful because she's sensing memory loss, or could?
It'd be an indicator of a degenerative condition. Go ahead and pop up that next slide there. So to me, one of the first things you would want to do is to look at and try to understand, because it's clear that she has depression and anxiety. She's giving you those indications. You're right, we don't know chicken or egg. Maybe we can figure out chicken or egg, but we can certainly try to target those symptoms, because regardless of whether it's a cause or an effect, it's going to have a negative impact on this person's quality of life. Now, sometimes when you target them, you get some sense about whether it's a chicken or an egg, because it doesn't respond the same if it's a function of the neurodegenerative condition, and that can be an indicator, but it's worth kind of getting into that and looking at that and getting a sense of that. I think that that's important. And to me, the other thing is then what do you do at this point in terms of your comfort level? If this is something that you've seen before, because you hit it with these medical risk factors, this could be just related to small vessel ischemic change. Your MRI could show you that. That may give you that information. And you may say, okay, let's focus on managing these things a little bit better, increasing your diet, increasing your exercise. Or the MRI comes back clean,
and it's got no small vessel change, and that makes you a little bit more worried and concerned. And so maybe at that point, you think about, let's really focus on treating the depression and anxiety. See what happens with that and follow you over time. We still want you to take good care of yourself medically because that decreases the chances of change. But we may just have to monitor you over time and see what's happened. Let's get these factors managed that we can manage and see what happens. But it really comes down to what your comfort level is about what you want to do with the next step. And then what the family's comfort level is with this. Some people really want to know. They really got to know. And if they got to know, then you got to refer them. Because we'll do the $1 million workup then, and that may include a PET scan. And it may include other things that will really drill down into it to really rule it out. But some people are satisfied with this level of answer. And if you're comfortable with it and managing and watching that, then it's good. But if you're not, then we're happy to take a look, or we're happy to discuss with these.
Mark, can I add something?
Yes.
Just from the depression subtlety point of view, I would also want to know, has she suffered from depression before in her life? You can see depression secondary to dementia, or as the cardinal sign of dementia presenting. I've seen that happen several times. But you can also have people who have a tendency to be depressed when they're sick, and they think they're sick right now. So it's depressing to think something's wrong with their body. So it can be an exacerbation of an existing condition, if you will, or it can be a new condition secondary to the dementia process. And I'd also like to know, what was the problem with her mother that upset her the most? I had one patient who said, I don't want to be like my Aunt Jane who tried to make tea with the Brillo pad. Don't tell me I have Alzheimer's because I don't want to be like that. And, that's an extreme example, and psycho ed might have to, tell her that people live with Alzheimer's disease every day, and it doesn't mean they're ready for a nursing home right away or begin the psychoeducation. But I'd like to know, what is she most afraid of she might turn into that her mother was like?
That's actually a burgeoning area of research these days, is this what's called dementia worry. So people who worry about dementia, and there's a difference between patients who have worry about getting dementia if they've actually seen it before, compared to those who haven't seen it before in terms of what the impact it is on them. Genetically, you have some increased risk if you've seen this, whether it's in your own family or caring for an in-law, that has an impact, but the genetic component is always there too. And the chances of some similarity, if it's genetically linked, does exist. But this is a whole new area of research. Worry about dementia and the impact that it has on you as a person and development of dementia. Anybody have any other comments or questions? I think that's the last slide, isn't it? Yep.
I would actually say that I always do something in addition to this. I think everyone does better and ages healthy, more healthy. They'll age better if they do follow the 3 rules of, regular exercise. I call it aggressive socialization, which is hard in the COVID era, and
Right.
the mind or the Mediterranean diet, whatever you prefer. And I think the data is pretty compelling that everyone can make a difference in their own clinical course if they do this, and so I think my patients seem to feel much better after telling them that it's not pointless and helpless. And
That there are things that you can do.
too, and that you can affect the course of this even if it's the worst. And I think my patients are much happier for feeling they have a little bit of control. And whether, we used to believe this might be true, but the data is really convincing that it actually is true now. And so no matter what what I think I'm going to tell them to do that.
That's a pretty standard recommendation we give, and I know Dr. Ward's not on right now, but when we see patients together, she always says this, and I really like it and try to use it. And that's, you never know also what we're going to learn and what's going to be coming up in the near future that may be an option. And so I don't want to give people a false sense of hope, but I want them to know that we're learning things all the time. The data about diet and exercise and its positive impact on changing the trajectory of the disease, we've just recently learned that, and it's really, really powerful data. So we don't know what we're going to learn yet. And so we always encourage our patients. Dr. Ward's really good about doing that, keep doing this, hang in there, because you don't know what we're going to learn that we're going to tell you about the next time that you come in to see us.
And also, like, go ahead, you go for it.
Oh no, Dr. Miller, I noticed you unmuted and wanted to see if you had a comment.
Oh, I did. In addition to asking the patient what she's worried about her mother, I would ask her what she's most worried about in herself. And I've had patients who, for example, their view of dementia is one lady I had who thought she was losing her faith in God because she prayed to God to help her memory and he didn't answer it. Her memory kept getting worse and she thought, I must be losing my faith. But, patiently explaining to her that it wasn't her fault, that this is due to a brain disease and we can try to help it. And it wasn't, in my view, even though I'm not a clergyman, a change in her faith. So people can sort of skew it in different ways. Another metaphor I use a lot of times, people will say, well, I hate being dependent on anybody for my memory. And, I hate to have to ask people because I can't remember. And if you equate it with a medical problem, let's say, now, two things. If it was reversed, if your husband had memory problems, you'd want to help him out. Well, sure, I would. So why won't you let him help you? And the other one is if you had a leg problem where you couldn't walk correctly, would you let your husband help you into the car when you had to go somewhere? And they'd say, well, yeah, sure. He would do that automatically. So what's the difference between that and letting him help you jog your memory if he has a better memory than you? If you use the term, the memory part of your brain isn't working as well as it used to be. If they have that sort of fingernails on the blackboard response to the word Alzheimer's, you can use the memory parts of your brain aren't working as well anymore, which is true. And you don't have to keep using that dementia term, which scares them. So, you can tailor your approach to a given patient depending on what you think they need to kind of get a grip on what they're dealing with at the moment.
Absolutely. Thank you, Dr. Miller. That's a great point. And thank you so much, Dr. Hout. That was an awesome presentation, and the case incorporated was great as well. So we have a few minutes here, about 6 minutes. I wanted to ask any of the participant spokes, did you all have any questions or comments about the example case or any part of the didactic? Feel free to chat it in as well.
I'll just say thank you. That was so clearly laid out and very helpful for me. So thank you. And I'm going to try to get a case or maybe a couple of cases for our next session, because I think that this question about caregivers is so challenging and how to support people who see that coming or who are in the throes of caregiving. So anyway, thank you.
Great, thank you.
And we do encourage any questions as well submitted through the online case form as well. So no worries if you don't have a full-on case, just even bringing questions to the sessions are great as well to facilitate discussion. For that, Jen, that would be awesome. Other comments or questions from the group as a whole for Dr. Hout or any of the hub members? All right, well, I'll give you guys 5 minutes back to your evening. Well, thank you so
All right.
much, Dr. Hout. That was awesome. We really
Thank you all.
So just a couple housekeeping announcements. Our next session will be on January 5th, and Dr. Navia will be discussing evaluation and diagnosis in primary care. So keep an eye out for that reminder. Feel free to reach out with any questions about the online case form as well. If anyone finds any difficulty with that, I'd be more than happy to help out. So thank you all so much, and we will see you guys next time. Have a good evening.
Bye.
So